We all know that a fairly stupid way of introducing someone important is by saying this person needs no introduction. Every wonderful person needs to be introduced, and especially if that person is Dr. V.R. Joshi, rheumatologist and physician. And especially if the audience consists of so many medical students who probably do not know him. Since I have been a student, I can easily rub it in and tell you, you don't know what you've missed. Actually, I should rub it in. Whatever I have learned as a physician in terms of attitude and knowledge is due to him. Back in 1987, I registered under him as an MD student at Nair Hospital. I was his last student before he left Nair Hospital and joined Hinduja College. I have spent a lot of sleepless nights, sir, thinking that I was the reason you left. I have seen him in his office, surrounded by books and journals, poring over a Lancet or an NEGM, writing in the margins. Something that taught me that if you want to be a teacher, you have to learn the most. I have seen him tackling overly anxious, self-proclaimed VIP patients in the OPD with patients, and I've learned that at no cost can you be angry at a patient. I have seen him treat extremely poor patients in the wards of Nair Hospital, and I've learned that the most rewarding experience comes when you don't charge. Dr. V.R. Joshi, if you see him when he comes up, has a very small frame, and I think the greatest concentration of passion for medicine per square centimeter surface area is in this man. He is extremely content with his material needs, does not own a mobile phone or a car, and extremely dissatisfied with the amount of knowledge he already has. I welcome Dr. V.R. Joshi.
I just center here. I just need the water.
Please, I'll give you a bottle of water.
You are in the glaring limelight. Can you just dim the lights, please, if you don't mind? Okay, it's still good morning. Thank you for the kind introduction. As you all know, introductions are a seed of exaggeration. So take it not only with a pinch of salt, but a big dose of salt. When I was invited by him to speak on symptomatology, he made it clear to me, or maybe he told me, talk in general, because possibly specific symptoms will be covered in the lecture series which followed his invitation. This was supposed to be a talk very early in the lecture series, but due to various reasons, including my health, work and whatever it is, I'm almost on the last day, almost the last speaker virtually. So I'm sorry for that kind of a delay. I hope you understand it. When he introduced the subject of symptomatology to me as a general thing, I accepted it rather too hastily. I thought it must be a very simple cakewalk. What is there to talk on symptoms? We can talk anytime, any day. As happens, you try to look into the literature and try to find out what information is available on the topic that you might be required to, or you're planning to talk on. Surprisingly, there is precious little on the subject of symptomatology. You don't get much, virtually nothing. So that means that I had to plan or really evolve this talk today. There is nothing at the background that I had to make this talk. So it might look a little disorganized, a little this, and let me assure you that what I'm talking today is nothing new. We all know this, we all do this. All that I'm doing is putting in one hat, one basket. That's all that I'm doing today. I started with looking at definition of symptom. I don't think we ever care to define symptom. And I thought it's time that I know what a symptom means. And I looked at the two sources. One is the Oxford Dictionary, which says it is a perceptible change in body or its functions indicating disease. That's a very simple, straightforward definition. I looked at Stedman's dictionary, also medical dictionary. It's a little more elaborate. It states, any morbid phenomenon or departure from normal in function, appearance or sensation experienced by the patient and is an indicative of disease. That means both these definitions, what they stress is that whenever patient complains to us with any symptom, it should be taken as indicative of a disease. I think that's pretty important. I just recall a young girl way back in Nair. She was a lupus patient, otherwise very well controlled lupus, would always come with her mother because her father was sick with neurological disorder. But the mother will always complain that this girl is difficult to manage. She just doesn't listen, doesn't do whatever you want to tell her, and I don't know what to do with her. She was on just 5 milligram dose of prednisolone, apart from other chloroquine, etc. that we prescribed that time. It so happened that her disease appeared to have a little flare. So I increased the dose of prednisolone, I think 10 milligram or maybe 15. And next time when the patient came back and the mother told me that she's a changed girl. She's very cooperative, very understanding, very docile. So all that behavioral problem, which was thought of as a psychological, growing children and all that we always talk of, was part of lupus, which we missed it. I missed it totally. So the message is, even if we don't understand what that means in terms of disease, let us not brush it off. Because that may not be correct. You might be really looking at a wrong side. The next thing that I thought I would look at is how does the patient look at the symptom? Obviously, when a patient suffers from a symptom or experiences a symptom, patient realizes that something is wrong. That's as simple as that. But often we do not necessarily run to the doctor. We feel maybe it's a minor thing, it will pass off, I don't have to do anything. But when a patient reports to us or when a patient comes to us, obviously is affected by that symptom. He has various things. It might be anxiety, it might be fear. Anxiety because he doesn't know what is happening. Fear because some of his friends had cancer with similar symptoms and he or she is worried that am I developing cancer? So the person might be worried whether I will be able to continue to work, what will be the financial impact. Or in diseases like lupus and ankylosing, worried about the next generation. Would that next generation get the disease? So there can be hundreds of things that the patient will have in the mind when the patient reports. So what we see is not the symptom, but we also have to understand what is the fear, what is the thought behind that symptom which brings the patient to us. I think that's important to realize, because then our approach, our treatment would to that extent be much more complete. The symptom, as far as the patient is concerned, is equivalent to illness. Patient, to him, I get headache. So I get headache. Patient is not knowing, patient does not know what the diagnosis is. And one of the important things that patient is asking of you and me is relief. Patient wants relief from symptom. Often we fail to do that because the disease is incurable, like happens in carcinoma with metastasis. The pain is the dominant thing. The patient knows that this is the end of the journey, but the patient wants relief from pain. He complains of pain, not of cancer, not the symptoms of cancer, he or she. So relief is important. Second thing is that sometimes we treat the disease in our own terms, we cure the disease, but the patient is not relieved of the symptoms. I do remember a patient of polymyositis or dermatomyositis might have been, whom we treated with the usual treatment, and for all practical purposes we saw that the disease was well controlled. However, every time the patient would come, he would say, "Doctor, my weakness is still there. I have not improved." And one had to ask the question, why is the persistent symptom? Is it because of steroids? Pseudomyopathy? No, the dose was very small. So, what the reason was that because of the polymyositis, a lot of muscle fibers were destroyed. So the bulk of the muscle had gone, it was replaced by fibrous tissue, and there was no way the patient could have become normal. So often the persistent symptoms does not mean that your treatment has failed, it might be the effect, and you have to explain to the patient that look here, this is all that will happen, you cannot improve beyond this. And I think that's another important thing that we need to keep in mind. Sometimes the symptom for the patient can be an escape phenomena. I again recall a young girl. She came with what looked like purpuric spots of her arm, especially one arm. It looked like some kind of a purpura, and naturally one is worried about what is happening. It's some hematological disorder. But when one looked at it, it was not purpura. It looked like as if something has been pricking there or punctured there. And then the history came out that her mother was a lawyer, rich, educated family. Her sister, who had done extremely well in SSC, was always she was being compared with her. That look at your elder sister was such, you also must do that. And it was that pressure of expectation that drove the girl to prick herself with some needle or something like that and produce a disease, and then say that because of this I can't write, I can't give my paper, I won't be able to do well. So for her, she was creating a defense to escape the expectation that were there. So there can be a variety of reasons why the patient can develop symptoms, and we again to say the same thing, that we must do that. And the point that I'm last make as far as the patient and we are concerned on this point is that this kind of an interaction, this kind of an interpretation can often happen when you see the patient. These days when you send the symptoms and the history on email and on a computer and all that, internet, that's not good. It tells you that patient has this, that, but doesn't tell you what the patient really has. What is the patient's main problem, what is the patient's full problem. So at least to me, seeing a patient personally cannot be replaced by any of the other things. They're convenient, they help you a lot, I have nothing against them, but we must know their limitation. Direct relationship with the patient, and also the patient develops a kind of a faith in you, relies on you, your attention to his details, asking what is happening, how it is happening. The patient knows the doctor is interested, you show them sympathy, empathy, whatever you have, and the patient is willing to come and stay with you for a longer time, even if not all right. And I'm sure all of us have experienced that some patients who don't get all right, still continue to come to you because they know you are interested in them. You are trying to do something for them. So I think that's an important thing. The next thing I was thinking was, how do we look at symptoms? What benefits or what advantages we have or whatever way you want to put down. First thing, of course, it defines the problem. If I have cough, I'm looking at the lungs. If I have a pain in the knee joints, I'm looking at arthritis. So it defines the problem. You straight will know that I have got to look at that. That's as simple as anything else. When we face a patient with symptoms, I mean, I'm not going to elaborate, but just to tell this, that we naturally want to know where is the pain, what is the quality of pain, what is the severity, what is the frequency, what brings out, what relieves it, and all that, all those kinds of things. But this precipitating and relieving is sometimes very important. Again, I remember way back in JJ Hospital, I was there as a reader in medicine. There was a JJ, he was a obstetric gynec registrar. And just the day on there he had to appear for practicals, she came to me, or came to the OPD ward drive, we were taking around, urticarial rash all over the body. And super uncomfortable. And then the residents told me, who were with me, so every time she has to go to exam, he gets this. So his urticarial rash was purely precipitated by the tension, anxiety, whatever you want to know, of practical. She couldn't face that. And of course, you give him medicines and send him, but that's what will happen to that. Another very important historical example is of John Hunter. Some of you know that he was one of the best known UK surgeon. He suffered from angina. And this is what he wrote. Whenever his temper was lost, he would get angina. So he said, some rascal, he wrote, would sooner or later doom him by riling him, by irritating him. And sure enough, he died of heart attack when he had an argument with someone in the hospital. So, precipitating factors, relieving factors do make a difference. We have to understand them and tell the patient what is happening. We also look for associated features. A simple, say, low back pain is so common. I mean, according to statistics, 80% of us at some time or the other get low back pain. You don't look at a low back pain and go on doing MRIs and everything. There is no need at all. But if that low back happens in an elderly person, or if that low back is associated with fever, it is associated with the weight loss, it is associated with some neurologic symptoms, obviously that low back pain is a serious matter. You can't just ignore it. So associated features also can sometimes, they change the connotation, the interpretation, and our understanding approach to the patient. So the associated features also are quite important, and one could go on giving many examples. We all possibly know them every day. Are some symptoms totally diagnostic? Very few, if at all. But say a young man says the doctor at the end of defecation, some drops of blood come out. You know this is piles which is bleeding. Or a fourth or fifth decade lady says that I've got bleeding nipple discharge. You think of carcinoma or spotting. So these are the symptoms which really focus on a disease. But most symptoms don't do that. If I tell you, doctor, I'm breathless, I could have cardiac problem, I could have respiratory problem, I might be anemic, I might be or I might just diaphragmatic paralysis, whatever it is. So they don't tell you what is the focus of the disease, but some symptoms do that, and we need to be quite aware of those kind of symptoms. What is important is no symptom is in isolation, most of them are together, we know that, but it's the sequence in which the symptoms develop which can tell you a lot more. I'll give an example. If there is a young man who comes to us with a pleuritic chest pain and a breathlessness, obviously you think, oh, is it pleurocytic effusion? Is it pneumonia? Could it be embolism? Could it be pneumothorax? All of them would produce this kind of symptoms. However, if you look at the sequence, there might be a little difference. A patient with a pleuritic chest pain will start with pain, and it takes time for the effusion to develop, so there is a gap between the onset of pain and the onset of breathlessness. So you know it is an evolved from a dry pleurisy to a wet pleurisy. On the other hand, in pneumonia, the patient's breathlessness precedes chest pain because we know pneumonia starts at the hilum and goes to the periphery. So it takes time before the pleura is involved. So the sequence is that way, chances are it is pneumonia. So even the same symptoms in combination, in different combinations can mean differently, and we again have to be aware of these things. I'm sure we all are on that. Symptoms also tell us about disease mechanism. Two examples. Chest pain, precordial. If it is brought on by exertion, relief arrest, obviously it is due to ischemic heart disease. You are talking of coronary artery disease, ischemic, maybe atherosclerosis. But if it is increased by swallowing, or if it is increased by turning the bed, that's pericarditis. It is inflammatory. So the same pain, its associated features can make a difference in the diagnosis. And you know, this is degenerative coronary artery disease, others you know it is inflammatory. Or take an example of again a backache. A backache which is worsened by rest is inflammatory. A backache which is reduced by rest is mechanical. So these kinds of things also play an important role. I'm really talking what we all do every day because there's nothing new on that, but I'm just trying to put everything as I told you in just one box or bag or whatever you want to say. Symptoms also tell you about progression of the disease. Obviously we go on, aaj kaisa hai bukhar, kal kaisa hai bukhar, and that kind of a thing. So it tells you about the progress of the disease. But some symptoms can be red flags. I already told you that. Fever, neurological symptoms, loss of weight in a low back pain are red flags. They alert you that, well, there's some major problem. So some symptoms carry that red flag tag with us. And there are other pitfalls and limitations. Are there any pitfalls or limitations with the pregnancy? Obviously, they can mislead you sometimes. And the best example is referred pain. A patient with shoulder pain possibly has a diaphragmatic problem, or a patient with shoulder pain on the left side possibly has a cardiac problem, or a patient with a knee pain possibly has a hip problem, or a patient with a hip pain possibly has a lumbar spine problem. So this kind of a referred pain can sometimes fool us for a pretty long time. The other limitation is the symptoms are not very sensitive to diagnose disease. Today we talk of diagnosing disease before the disease manifests. You want to do a pre-symptomatic stage, and obviously there is a huge pre-symptomatic stage in the majority of disease. A diabetic doesn't become diabetic today, a hypertensive doesn't become hypertensive today, or an arthritic doesn't become rheumatoid arthritis today. The disease is evolving over a period of time, and the symptoms give you no idea of this period. So in that sense, if you are looking at very early diagnosis, or what we call diagnosis before the disease comes up, symptoms have no role. The symptoms can really be there, but that's advanced medicine. But for day-to-day medicine, symptom is the only thing that tells us about the patient what is there. The second thing is, again another important example. I still remember my Mrs. Joshi's elder sister, cousin sister. Her husband one day just phoned me up at night saying, I'm having epigastric pain, I'm vomiting, I'm not feeling well. Can you just come and have a look at me? I went and he had a myocardial infarction. He never thought he had any chest pain at all. And this is a very common thing. Epigastric pain with all that could be myocardial, really not anything to do with the stomach. So these are the pitfalls that we can do that. Sometimes the patient doesn't appreciate the seriousness of the symptoms. Bad for him. The point to remember is almost 30% of the patient's symptoms we listen to cannot be explained. A lot of symptoms. I mean, I have been patient long enough, so I know how many of my symptoms have been explained by my doctors to me. I know that. A lot of symptoms don't get explained. In fact, they shrug shoulders. I mean, even I do that. You shrug shoulders, or you say, nahi, jaan do kuch. You know, you just brush it off. But I give you that example of that girl. I don't think you can brush it off. And when you look back, again talking very personally, you know what it meant. So I think suppression of symptoms or ignoring symptoms may be bad. Another important pitfall is malingering or hysteria. That's a big, big problem. I remember an assistant to an ophthalmologist, a very leading ophthalmologist in the suburbs. his assistant started saying that she has developed only a tubular vision. And she can't see the periphery. Naturally, you are worried about, is there a pituitary tumor, is this, that, what is happening. All investigations done, nothing found. Even, it didn't occur to me what she had, honestly. It didn't occur to me, and we just wondered what is what. It so happened that this girl was feeling that I'm going to lose my job. And she was possibly, the doctor was losing his interest in keeping her for a long time. So she wanted to remain in the contact with the doctor with a ophthalmologic symptom, so that he will constantly sort of be looking after her, caring for her, not sort of saying, no, I can't work, so don't remove from the job. So it can be, she picked up what the ophthalmologist does, loss of vision, peripheral, and she was following that. So hysteria, Malingbearer, we know of Munchausen syndrome, and that's a very famous thing of patients who get this. So we have to be very aware of these kinds of things. Sometimes the significance of the symptom can change. Again, I'll give an example. Long back in Hinduja, this was a well-known person. He was diagnosed at enteric fever, culture proven. That time ciprofloxacin used to work, received full, complete course of ciprofloxacin, became afebrile, and after a period of some 8-10 days or so days, started getting fever again. The initial impression of his treating physician naturally was that there is a recurrence of enteric fever. But that's odd. I think that if you have made a correct diagnosis, and if you have given a full treatment, if there is a recurrence of the symptom, there is something else happening. It is not that disease. Now this gentleman had perforated, there was an intestinal perforation, and what he was having fever was due to an abscess. So it was not nothing to do with enteric fever, it was the consequence of enteric fever. But his fever was due to an abscess due to an intestinal perforation. I remember another lady who suffered from falciparum malaria, properly treated, everything okay, came back with fever again. Obviously same argument, is it relapse of malaria and this, that? No. What she had was that she has had, on an X-ray, just that little suggestion of a widening of the mediastinum. A CT showed lymph nodes, and a further diagnosis showed it was tuberculosis. So please remember that if a symptom reappears after proper, complete treatment and a correct diagnosis, think of an alternative possibility. Rather than harping on the old diagnosis, it can sometimes be wrong. We also want sometimes to quantitate the symptom. आज कैसा है, mild, moderate, कल से अच्छा है. But it is terribly subjective. If you want to study a phenomenon, say like pain, and if you are giving the patient an analgesic or a drug which reduces the pain, you want to quantitate it. She can't say, sir, doctor, पहले से उससे अच्छा है. But what does that mean? You don't know what it means. So you need to do a way of quantitating. As far as the pain is concerned, you are familiar with the so-called VAS, a 0 to 100 or 0 to 10 scale, which patient asks, the severity of pain is marked on the scale. And yesterday it was here, today it is here, today it is here. That tells you how the symptom is moving forward or backward, and the degree of change tells you the effectiveness of your therapy or whatever you are doing. So there is sometimes a need, or the best example is say fever. We take temperature every day. Now that's quantitating a symptom. Other patients have bukhar thoda sa kam hai, zyada hai, I can have no quantitation. So wherever possible, we must try and quantitate objectively, subjectively, as far as, or semi-objectively, we need to do that. Last thing about this sensitivity, the sensitivity of the, or the positive predictive value. You know, there are a few studies. Suppose you have a patient of HIV, and the patient comes to you with cough expectoration. What are the chances that the patient has pulmonary tuberculosis? A lot of chances, but there could be other things also. So a study has been done where fever, cough, sputum, hemoptysis, and what is the sensitivity of each one of them to make a diagnosis. Because the same symptom can mean different things. Take example of malaria. If I get fever with rigors and splenomegaly, in Mumbai it is malaria, but in East it is Kaladhar. The same symptoms. So the interpretation of the test or interpretation of symptoms, or the positive predictive value or the negative predictive value, is governed by the environment in which the patient is. We always used to face a diagnosis of ANA positive, I have got lupus. If you do an ANA test in 100 people, 5 will be positive. Do you mean to say the incidence of SLE is 5%? You'll be lucky to see one patient in your whole life. So obviously it is false. So we have to be careful on that. Lastly, about the symptoms, therapy. I said that before also, it is important to treat patients symptomatically. Because that's what patient primarily wants. And of course, the curative therapy that we do, there are limitations to our symptomatic treatment, but that should be as important. And that's why when you read books, curative therapy, symptomatic therapy. The symptomatic part is equally important. Very difficult to treat, honestly, but you need to be aware of that. Have I 2 minutes, 5 minutes more? 5 minutes? I just tell you about 2 cases, just to tell you the importance of history. This was a patient I saw very early when at Hinduja. The resident was taking the history, I was sitting and noting, doing something. The history about this man was suffering from fever, repeated episodes of fever for the last 25 years. I am not exaggerating. And the fever will last for 2-3 days. Would it become alright? Obviously investigated extensively, treated extensively, but no relief. The thing that came to the mind is, could this be familial Mediterranean fever? So with that thought, we asked him this, do you get abdominal pain with that? Yes, I get abdominal pain. Is the abdominal pain sometimes so severe that the doctor wants to operate on you? Yes, once I was almost taken to the operation table. But it lasts for 2-3 days and goes away. That's typically familial Mediterranean fever. There are no tests available at that time, now is genetic tests available. So the history of that fever, the way it was, the associated symptoms, told you that this is most likely familial Mediterranean fever. We put on colchicine, 2 tablets of 0.5 milligram colchicine. His fever disappeared forever. This patient came back to me 20 years down the line just to see me. Absolutely happy, no fever, continuing colchicine, totally all right. So, giving symptoms their due, because we tend to ignore. Another lady, which again referred to us, and she came with hemothorax. But she looked very anemic and I was referred possibly for fitness or something. When taking her history, she told me that I have always been anemic. She looked very anemic. And if you looked at her reports, it showed you that this was iron deficiency anemia. So you obviously asked, do you have menorrhagia? No. Do you have hematemesis, or has stool been examined? She said everything has been done. All reports are normal. They can't find my cause of recurrent anemia, which was quite severe, some 7-8 grams per cent. And while I was just talking to her, I don't know what question I asked, I can't remember, it a long time back. She said, I get epistaxis very frequently. I said, why? And she said, this is our family trait. A large number of us get epistaxis. And that clicked, that this is familial hereditary hemorrhagic telangiectasia. Her brother was there, we looked at him, and sure enough, with eyes you could show the telangiectasia. So again, that epistaxis which you might ignore, unless patient is hypertensive or crisis or all that, was the clue to diagnosis. So the point I am trying to make before you is, symptoms which you ask to every patient every day, we listen to them and react, but often we don't give the symptom the due that the person consciously don't do that. Let me put it very correctly. We do all this what I am talking to you, but we never consciously think the symptoms forms one of the most important components of the art of medicine. We all talk of art of medicine, and I think symptoms, their understanding, their interpretation, treatment or whatever you have, possibly is an extremely important component of the art of medicine, which is essential no matter how much technology advances. Thank you very much.
Thank you very much, sir. Thank you so much. I will just like to present to you a memento. If you can just come there, and I'll request Dr. Suraj Dhirwani to please Thank you so much, sir. It's the 19th edition of Harris. Thank you so much. A big round of applause again for sir.